With the ever-growing number of patients, clinicians need a large armamentarium of antifungal agents because many patients don't complete the treatment because of high toxicity, lot of drug-drug interactions, and some can't afford it. Therefore, clinicians need to have a good insight into risk versus benefit of using these antifungal agents. There is also growing antifungal resistance because of selection pressure. Here, I am Professor Anuradha Sharma. I bring you a brief review of current and future antifungal agents. So, there are several factors which matter in the outcome of the patient, and most important is immune status of the patient. If we recover neutropenia rapidly, then half the work is done. Another is site of infection, whether drug penetrates there or not, like CNS, eye, urinary tract. Then presence of any foreign body, any device, catheter, like central venous catheter, and that is very important if it is responsible for the source of infection. And of course, dose and duration of therapy, and it varies, and one should be very familiar with that. So there is a timeline showing initially polyenes were the drugs discovered, and nystatin, which had no systemic activity, was used only for local application, and it is still being used. Then came amphotericin B, and it still remains the gold standard of treatment for most severe invasive fungal infections, especially where diagnosis cannot be established. Then came era of azoles, and ketoconazole was used in high number, but because of its toxicity it has been abandoned, and better molecules have been discovered after that, and fluconazole became the drug of choice for candidiasis after AIDS was introduced. Echinocandins were discovered in the first decade of the century, and they remain now the drug of choice for invasive candidiasis, especially candidemia, because of superior survival outcome. And in past decade, the only drug approved has been isavuconazole, and it is very promising azole with very few drug-drug interactions and toxicities. Let's have a look at the classification of antifungal drugs. So, fungi is a eukaryote, and it has a cell wall, then a cell membrane which resembles the mammalian cell. And there are three important classes of antifungal agents which work on cell membrane, that is ergosterol synthesis. In a sequential manner, they influence the enzyme activity. So from squalene, lanosterol is formed. From lanosterol, ergosterol is formed. So allylamines, that is terbinafine, acts on squalene epoxidase enzyme, inhibits it. Azoles inhibit cytochrome P450 14 alpha demethylase enzyme, and polyenes act on the cell membrane forming pores and leading to loss of membrane integrity. Then cell wall acting agents, that is echinocandins, have been discovered, and therefore they have very few toxicity in comparison to these agents. And again, this is systemically active, but it is not available as oral agent. Then there are other antimetabolites. They are cytotoxic drugs. So 5-flucytosine, it affects the DNA, RNA, and protein synthesis. And griseofulvin, which attaches to mitotic spindle and affects cell division. So these are the examples of various classes. Allylamines, terbinafine, naphthene. Antimetabolite is flucytosine. Polyenes are amphotericin B and nystatin. Azoles are broadly classified into imidazoles and triazoles. Imidazoles are used for local application and triazoles are being used systemically. Echinocandins are caspofungin, anidulafungin, and micafungin, and recently approved rezafungin. And another new agent which has been approved by FDA is ibrexafungerp. The other two in pipeline are olorofim and fosmanogepix. So this is a diagram showing the site of action. So allylamines are terbinafine and naphthene, and they get concentrated in skin, hair, and nails. So therefore, they are terbinafine is used for dermatophytosis, onychomycosis, chromoblastomycosis, and sporotrichosis. Though this has a broad spectrum of activity, and recently it has been approved for treatment of Lomentospora and Fusarium, especially Pseudosporium, which is highly drug resistant inherently. Then antimetabolites are flucytosine. It has limited activity and mostly it acts on the yeast cells, that is Candida, Cryptococcus, and Rhodotorula, and some demetaceous modes. It should not be used as monotherapy because rapidly drug resistance emerges, and it is combined with Fluconazole or Amphotericin B, especially in cryptococcal meningitis. It is not active against commonly isolated molds. So flucytosine has excellent bioavailability and it penetrates the CNS. The orally available drug concentration are 25 to 37.5 milligrams 6 hourly. It has a narrow therapeutic range because at higher concentration than 100 microgram per ml, there is increased hepatotoxicity and bone marrow suppression. So therapeutic drug monitoring is very important when this drug is given, but it is not so commonly available. Then another drug is griseofulvin. It is again used for dermatophytosis, but terbinafine has similar activity during lesser time, over 2 to 4 weeks period. It is superior in microsporum scalp infections where it is most commonly prescribed. Then polyenes, amphotericin B, as we know, is the gold standard treatment for severe mycosis. There are two forms, conventional, which we call amphotericin B deoxycholate, and other lipid formulations. Their efficacy is same. There is only difference in toxicity. So amphotericin B deoxycholate has cumulative nephrotoxicity, and therefore liposomal amphotericin B is now used in developed world. Recently, oral lipid nanocrystal has been studied and it has very promising results for cryptococcal meningitis. So it binds to ergosterol in cell membrane, forms pores, and leakage of intracellular contents occur, especially loss of potassium and magnesium ions. And that is how cell lysis occurs, and it is rapidly acting antifungal agent. There is direct membrane damage by free radicals. So it is a fungicidal agent with wide distribution in tissues, and it is effective in CNS also. So it acts on Candida, Cryptococcus, Aspergillus, Mucorales, as well as on endemic fungal pathogens. There are some inherently resistant fungal species. There is no acquired resistance against amphotericin B because it's a ergosterol. It's not a protein molecule. So these inherently resistant species have a different molecular form of ergosterol, and that is how they are resistant. So Aspergillus teres, which is increasingly being isolated, there we cannot use it. Then Fusarium, Pseudosporium, Lomentospora, Trichosporon, these are difficult to treat mold infections. And Candida lusitani and Candida auris, as we know, they are inherently resistant. And then certain demetaceous fungi. So if we are suspecting any of these, then we have to be very careful when we are using polyenes. Dosage for deoxycholate preparation, it is 0.5 to 1 milligram per kg per day, whereas for liposomal amphotericin B, it is 5 to 10 milligram per kg per day. So toxicity with deoxycholate is almost 4 to 5 times in comparison to liposomal amphotericin B. So the thing, it can be managed by previous saline loading with 1 liter saline before giving the dose will reduce the nephrotoxicity. Then it should not be combined with other nephrotoxic drugs. Then electrolyte imbalance occurs because of loss of potassium. It should be, the renal function test should be monitored, and at times serum this potassium supplement may be required in the patients. Then because it inhibits erythropoietin, with time normocytic anemia may appear, so CBC should be monitored in these patients. It can lead to renal tubular acidosis, especially in association with any other disease or drug which leads to acidosis. Then infusion related side effects are very troublesome for the patient. They are nausea, vomiting, chills, rigor. So they can be managed with one of these drugs like acetaminophen, hydrocortisone, or meperidine. Then comes next important class, azoles, which are very potent and they have overlapping spectrum on various fungi. So they disrupt cell membrane synthesis by binding to cytochrome P450 lanosterol 14 alpha demethylase enzyme. These are examples of imidazoles. The most important have been ketoconazole, clotrimazole, miconazole, and recent have been terconazole, teoconazole, all these. So they are used for local application for vulvovaginal candidiasis and dermatophytosis. The triazoles are fluconazole, itraconazole, voriconazole, posaconazole, and isovoconazole. They are fungistatic for all yeasts and fungicidal for molds. And therefore, because of this fungistatic effect, the selection pressure happens and mutants with drug resistance emerge. Therefore, adequate dose is very important to prevent emergence of these resistant mutants. So these azoles, triazoles, they have overlapping spectrum, but their affinity for target enzyme varies. So they have individually different effects and toxicities as well. So fluconazole is effective on Candida, Cryptococcus, and coccidioidomycosis, but it is not effective on any mold. So next salt was itraconazole. It remains the drug of choice for endemic mycosis, and it has the broadest spectrum of activity, but it also has largest number of drug-drug interactions. Almost 1,000 drugs interact with it. So this is the drug which is stopped midway during its therapy. And then voriconazole is another very potent drug, and the only drawback is that it has its unique side effects, which can be very troublesome to the patient, and therefore therapeutic drug monitoring is important, and it is not effective on mucorales. Then Posaconazole has been approved for prophylactic use in neutropenic patients. Isoconazole is an azole with lowest toxicity, and here toxicity is unique that there is shortening of QT interval in comparison to rest of the triazoles, which prolong the QT interval. And it also has lowest number of drug-drug interactions. And recently it has been found to be non-inferior to Voriconazole for treating invasive aspergillosis. And it also has some activity against mucorales. So, Fluconazole is the drug which achieves adequate urinary concentration and reliable serum concentration. So, it's the only azole which can be used for cystitis. So, all these drug-drug interactions are through cytochrome P450 enzyme. Either they inhibit it or they act as substrate. And Itraconazole having the most and Isavuconazole the least interactions. So any patient receiving azoles should be thoroughly analyzed for various medications patient is taking, and we should avoid these drug-drug interactions because they can be fatal. So especially with drugs like anti-seizure drugs, anticoagulants, rifampicin, statins, tacrolimus. And there is a very good program available on UpToDate Lexi Interact to verify the various to avoid these drug-drug interactions. There are some triazole resistant fungi as we discussed. So either it is because of selection pressure, because of use of azoles, or it is inherently resistant. So inherently resistant to fluconazole are Candida krusei and Candida auris, and it is because of ERG11 mutation. Whereas Candida glabrata also shows high resistance to fluconazole, but it is because of presence of a efflux pump, and therefore it shows resistance to a large number of drugs. And Cryptococcus neoformans rarely shows transient adaptation to azoles because of aneuploidy. Then there are non-Candida, non-cryptococcal yeasts which show resistance to fluconazole like Rhodotorula, Vichromyces, Saprokeet. Then Aspergillus fumigatus shows acquired resistance due to CYP51A mutation because of wide agriculture use of azoles. Then there are two cryptic species of Aspergillus which are inherently resistant to azoles, and remember Voriconazole is the drug of choice for invasive aspergillosis. Therefore it is very important to identify these species, and it can be done only by molecular methods. So Aspergillus tubangensis and Aspergillus calidoastus, they are resistant to azoles. Then mucorales are inherently resistant to Voriconazole, and these are difficult to treat molds, Pseudosporium fusarium and Lomentospora. So Fluconazole is the very commonly used azole. It has low toxicity, it is cheap, it has excellent oral bioavailability, and it is widely distributed in tissues including central nervous system. And these are its uses, and in candidemia it is used for step down therapy, but it remains a pregnancy category D agent, and through some recent studies it has been suggested that only single dose of 150 milligram is permissible in first trimester of pregnancy, and 300 milligram fluconazole will be teratogenic. So it should not be used. And for renal clearance, 50% dose reduction is required when the creatinine clearance falls less than 50 ml per minute. And rest all toxicities, that is hepatotoxicity, cardiac toxicity, neurotoxicity, and prolongation of QT is shared with other azoles. Adequate dose of fluconazole is very important to prevent emergence of acquired resistance. So these are various conditions in which the recommended concentration of drug should be used for the required period. Then next important itraconazole is azole is itraconazole. It has broad spectrum as we discussed, but its absorption orally is very erratic. But it has been overcome with the availability of suba itraconazole, and this can be given both with food or proton pump inhibitors. Then it shares its adverse effects with other azoles, and it also produces hypertension, and it has a negative inotropic effect and can lead to heart failure. So it is clinically used for most cutaneous and systemic mycosis, then dermatophytosis, and for non-life-threatening non-meningeal forms of endemic fungi. It is second-line treatment for invasive aspergillosis and allergic bronchopulmonary aspergillosis, and also for fluconazole-resistant Candida glabrata and Candida krusei. Voriconazole, it is widely distributed, especially in central nervous system. So apart from invasive aspergillosis, it is the drug of choice for fungal meningitis, and also for these difficult to treat molds, Pseudosporium fusarium, Lomentospora, Pheohyphomycosis, Copularapsis, Purpurocilium. For all this, Voriconazole is used. It is also active against Candida krusei, Aspergillus teres, and Pseudosporium. All these agents are usually resistant to a large number of antifungal agents. It has unique adverse effects. So there can be transient visual disturbance in 1/3 patients, especially after 30 to 60 minutes of administration, whether per orally or parenterally, with peak serum levels. So patient complains of flashes of lights. It is called photopsia, then photophobia and color changes, but it is transient. Whereas due to neurotoxicity, when serum levels are more than 5.5 microgram per ml, it leads to hallucinations, both visual and auditory, confusion, agitation, myoclonus, and it is important to differentiate it from visual disturbances because it shows there is a toxic level of drug in the serum. Then it can also lead to photosensitivity rashes and skin carcinoma with long-term use in immunocompromised patients. It leads to nail changes, alopecia, xerosis, which is all reversible. It has another unique property that it is the only fluorinated antifungal, and it gets deposited in the bone, leading to periostitis and exostosis. So painful bony surfaces can be present, but this is reversible. So it has a narrow range of narrow therapeutic range of 1 to 5.5 microgram per ml, and therapeutic drug monitoring is very important because in different patients there is like in children, they are rapid metabolizers. So they may need higher concentration to achieve proper clinical effect. Whereas Japanese and some non-Indian Asians are slow metabolizers. So their dose adjustment will be required to prevent toxicity. Then Posaconazole, which is a prophylactic drug, and it covers mucorales as well. So it had again erratic absorption, oral absorption, and therefore now delayed release tablets have been made available, which overcome this shortcoming. There there is wide patient variability in its peak serum concentration. So it requires therapeutic drug monitoring. Then it shares all the side effects like other azoles. FDA has approved it for prophylaxis in neutropenia, in oropharyngeal candidiasis, and oral step-down therapy in mucormycosis. Next important azole is isovoconazole. It is available both as oral and IV, and it has predictable pharmacokinetics. So fortunately, we don't need any therapeutic drug monitoring. It has long half-life, and it can be taken with or without food. So it has several advantages over other azoles, and it can be co-administered with drugs which prolong QTC interval because it causes QTC shortening. But it should not be administered, or it should be taken care of when given with methotrexate, tacrolimus, sirolimus, cyclosporin, glucocorticoids. It has been approved by FDA for invasive aspergillosis recently because it has lesser side effects than voriconazole and it is non-inferior, and also for invasive mucormycosis as step-down therapy after instituting liposomal amphotericin B. So these are important classes of antifungals: polyenes, antimetabolites, and azoles, which are very widely used and they are very potent antifungal agents and used across even resource limited countries. In next lecture, we will talk about echinocandins and recently available antifungal agents. Thank you. Join me there.